Good evening, everybody. We'll get underway because we've got plenty of you in the room already. Welcome to the latest Basra and Steroplast Injury Rehab Network. It's a pleasure to have you all on board. This evening's event follows Len's previous webinar we did on the athlete's shoulder that was extremely popular, had lots and lots and lots of questions. I don't even think we scratched the surface with the questions. And Len very kindly stepped up and said he was happy to come back and do a session dedicated to that. So that's what we're here for this evening. As always, it would be great to know who we've got in the room, so please introduce yourself in the chat box. Some housekeeping notes: we'll send certificates to all of you joining on the live event tonight. What we'll do, we'll run through some quick introductions so we know who we've got, and then the whole session is going to be stimulated by your questions, and we'll discuss responses amongst the panel. Please put your questions in the Q&A box at the bottom. You should be able to see on the graphic there which one that is. Please don't post them in the chat because we won't pick them up. And before you do post your question, just have a look at what people have already asked. You can upvote them and we'll take the most popular questions. So rather than duplicating what's already there, please just give them a thumbs up and it'll bump it to the top of our list. A little bit about Basra. As a host of the event, we're the professional association and regulator for sport rehabilitators. Since March 2020, we've been hosting CPD webinars just like this on a regular basis. If you'd like to support our work in doing so, you can become an associate member and the benefits are up on your screen there. That's just £5 a month and we'll send you some info afterwards. Obviously partnered up with Steroplast, who we've been working with throughout to deliver these events. Very grateful to Andrew Watson, who'll just do a quick bit of an intro there.
Ali, thanks everyone for joining, and yeah, thanks very much for the panel and for Len for sort of the good idea to get this together. I hope you find this evening useful. So just a quick introduction to Steroplast. We're a medical company based in Manchester, and we're working in partnership with lots of teams, organisations, and really pleased to be working with Basra on this series of events, which actually has been a positive result of COVID in some ways, that we've been able to bring these events and the expert guest speakers that have kindly given their time to speak. So if you could just move it on one, please, Ali. So we started the Injury Rehab Network in 2019, and the idea was to provide a forum for people that are working in sports injuries to collaborate and network, and hopefully we will be able to bring people back together face to face soon. But for now, the events like this one are online, and you can see the schedule of events that we've got in the diary here. So the next event after this one is with Angela Jackson, who will be talking about developing younger athletes and managing overloaded younger athletes. As you can see, we've got a schedule up until the end of October with the web link for the events for the year in there. So that's it really. Thanks very much. Hope you find the session useful. I'll hand back over to Ollie, and yeah, look forward to hearing some good debate from our panel members.
Yeah, thanks, Andrew. I think it's going to be a great event. Well, I know it's going to be a great event. We've got 3 brilliant speakers lined up and we cover all bases. We've got some questions to start us off as well. So those of you who very kindly submitted them when you registered, there were some brilliant questions in there, and we've kind of cherry picked out some themes to get started with. I'll run through some introductions. So first of all, many of you will have already met Len. You'll have attended his previous talk. Len is a consultant orthopaedic surgeon working as part of a large upper limb unit at Wrightington Hospital, and also works in private practice in Manchester at the Arm Clinic. Len established and runs shoulderdoc.co.uk and is passionate about patient information and education, as well as providing the best quality care with his MDT teams. So we've also got on the panel tonight Ethan Stamp. Ethan is a sport rehabilitator for Sale Sharks. After spending some time working in the academy program, he's now part of the performance team with the senior squad. Ethan graduated from the University of Salford sport rehab program, for those of you who are on this evening that are local to Salford. As part of that, he also worked in Minnesota, USA with the collegiate athletes out there, and has also completed his MSc in strength and conditioning from the University of Edinburgh. So we'll be discussing that angle as well this evening. We also have Doug Jones. Doug is a physiotherapist and the director of Altius Healthcare. He's worked full-time in professional sport for over 10 years in both Premiership and International Rugby Union. And he has more than 17 years experience working with various teams, including Sale Sharks, London Wasps, England Rugby, and his work in private practice as well. Doug established Altius in 2016 and now leads an MDT in his clinics across Manchester. So that is our panel, a stellar lineup. We said we'd get started on a topic that many of you raised in the questions leading into tonight, which was around shoulder impingement. And we'll touch on management, interventions, rehab, bit of return to play. So if I could maybe throw this to the panel, if we can start with just an overview of our understanding of shoulder impingement. I know it's slightly contentious as to whether we should call it that or whether it's shoulder dysfunction. It's lots of different names going on at the moment. But Doug, can we maybe bring you in just to start us off with impingement and touching on its recognition, initial management, perhaps, and we'll go from there.
Hello, everyone. I guess with that, impingement is this sort of term that describes mechanical pain where the subacromial space is enclosed for whatever reason. We all love a syndrome, so it's a nice word that we use time and time again in clinic to help the patient understand what's happening to their shoulder, and that impingement is for me, it's a useful term in that respect. I mean, I diagnose it clinically, and I hope to try and show the patient in the first session that I'm with them that they can control impingement. They can control the severity of pain depending on how they move, and that it is fundamentally a movement disorder rather than focusing on a specific tendon that's being pinched. So I try and use the term to settle patients down. I use it positively, and I talk about it's a movement disorder, and that's the way I approach impingement. Sometimes I think it's useful to show them video, so I often get them with their shirt so you can see the shoulder moving. iPhones are great now, and I video them moving and coach them through the movement pattern that's dysfunctional, and we slow it down and we talk about where their pain is in that painful arc, and then demonstrate good movement and try and get them to copy that. And that's normally my first session, really.
And what will the kind of management treatment side of things consist of for you? Is it biased towards exercise rehab, or kind of what's your approach?
My approach is very, very sort of educational, and it is all about reassuring patients that impingement is a syndrome that they can control, and teach them what good movement looks like. And we all often, providing they're asymmetrical, we use a right v left kind of pattern, and then we show them what dysfunctional looks like. And that is my approach. I don't use any specific exercises sometimes we use, maybe an external rotation force, and sometimes that helps them take their pain away. But very, very quickly in the first session, I'll hopefully be able to get my hands on their shoulder blade and get them moving free. And then I want them to leave that session with an understanding of how they can reduce their pain by controlling their movement better. And that's my fundamental approach. And
we know that there's a continuum of these injuries. So to bring Len in. And when somebody is failing, for want of a better word, failing conservative management, and we end up seeing more severe cases, what will that look like with you? So what's your approach to more severe impingement cases and patients?
Yeah, absolutely. I think I just sort of completely agree, obviously, with everything Doug says. Just to highlight a couple of things of which he said to lead into what you're asking is the vast majority of impingement cases, which I agree, impingement is a symptom and sign. It's not a diagnosis as itself. So it's a symptom and sign. The cause in the vast majority of cases that, therapists will see are what I call dynamic impingements. They are the muscular, postural, work-related types of impingements. And just again to expand on what Doug's saying, is what you'll look for is, does your modifications like scapular correction, does your cuff activation, does your scapular assistance all improve their symptoms? And if that does, then they're going to respond well to a non-interventional approach. So that's key. So for me, I would do that assessment as well on any patients that are coming to me. If they're coming to me from Doug or Ethan, I know that will have already been done. And it was great, again, to reinforce again what Doug said is, it's not about doing tons and tons of exercises. I've had impingement myself. It's about activity modifications, education, and then assessing what you're going to address in terms of, specific exercises, so cuff weakness, scapular weakness, that sort of stuff. And most important thing for me is no painful exercise. I'm sure Ethan and Doug, or I'm glad to see Ethan's nodding. So yeah, the exercises would not reproduce the pain. So the next thing then is, do they have passive impingement? So with a correction test, that doesn't improve their symptoms. So that means that there is probably some sort of structural cause for their pain. So as Doug said, impingement is something affect the subacromial or the rotator cuff space. So then you need to, for me, it's looking for what the cause is. So is it calcific? Is it something in the tendon? So calcific tendonitis, rotator cuff tears, severe tendinopathy with cuff dysfunction. Is it something in the shoulder joints, such as instability in younger patients, or frozen shoulder capsulitis or arthritis in older patients? Is it something in the AC joint, so AC joint arthritis causing impingement? Is it, the so-called spur, which we know is often normal, and sometimes it's a combination of tendinopathy with a large spur or AC joint problem? Or is it neurogenic, so within the muscles, so like getting to rare things like suprascapular palsy or something else? So that's really where and then treatment will be determined on those investigations to find a structural cause. So that's really it in a nutshell. Somebody asked about tendinopathy. Sorry, Nikki asked about tendinopathy. And that's difficult because generally almost all your wheelchair athletes, if you scan them, will have tendinopathy. So don't treat the tendinopathy, treat the pain. Easier said than done.
Yeah, I think you've said in the past as well then, Len, that you rely quite heavily on your subjective assessments with patients, but are there instances where imaging will come into it? What's the value of that in these cases?
So exactly. So, imaging is looking for many of those structural causes. Again, imaging will depend on what you have available easily. So, for me, I'm very fortunate. We've got everything available. So, an X-ray will give you a lot of information on the joints. If there's calcific tendinopathy, but you need to have 3 views. Very important. Ultrasound scan will give you a good appreciation of the superficial structures, but not the deep structures. MRI will give you a good appreciation of the soft tissues and the bones, but actually is worse than ultrasound and good X-rays for calcific tendinitis. So they all have pros and cons. So just getting an MR scan is not necessarily the answer.
Let's talk a little bit, because I want to get Ethan in on the conversation as well. On the later stages of rehab, Ethan, and when we're looking at return to play for athletes that have had previous impingement, what's the focus of rehab? And we had one, just to throw it in for something to think about, we had a really specific question around proprioceptive work for shoulder impingement as well.
Yeah, definitely. I mean, to follow on from what these guys have said, impingement per se can definitely be multifactorial. So there's so many different things that could cause it. And as Doug said, if you can establish an element of pain-free movement, or if you can improve their symptoms, or even better, take them away completely, then that gives the patient some immediate relief and understanding that this is not the end of the world. Ultimately, it's more likely to be going on for a while. It's typically a kind of overuse in nature. So if it's been going on for a while and they've been suffering, if you can immediately relieve their symptoms or settle the pain down, it will settle their brain down as well. And if you can get that buy-in initially, then it's going to make the rehab process so much easier. In terms of progressions, ultimately, you want to get them moving and working as pain-free as possible, as quickly as possible. As Len said, you don't want to be trying to jamming them through painful movements, because you're not going to make it any better, and they're probably not going to come back to you. So if you can get them moving, get them strong, ultimately, the movement quality is the most important thing. So if you can establish pain-free movement, then repeat it, get that proprioceptive nature in there. If previously they weren't able to get past 90 degrees, or even if they can only get to 90 degrees before pain kicks in, and get them working around just before there, get them used to being in that range, get them used to pushing the boundary slightly, getting used to strengthening through all the ranges they can now achieve. In terms of returning to play stuff, I guess it kind of depends on what the player or the patient, what the demands are. If you've got someone who's an overhead athlete, it's probably going to be slightly more challenging, because they're going to need to be a lot more dynamic. They're going to need to be strong, obviously, overhead. Things are going to be slightly more elastic and dynamic in nature. Things have to work faster. Whereas if you've got someone who's just coming off the streets, or you've got someone who's actually not going to spend a lot of time with their arm overhead, then it's not going to be, in terms of strengthening those ranges, it's going to be less of a focus, albeit you want to achieve it. You want to get them pain-free in the demands of their sport, or the demands of their tasks. So you can do various strength tests. You can do rotator cuff. It depends what kind of equipment you've got. If you've got a set of cables, you can do side-to-side comparison, like Doug said before, is trying to address any imbalances that may be there. If you've got fancy isoconnected dynamometers, you can go and use them if you want to. But in terms of keeping it simple and using the equipment that most people have got, ultimately you want to assess the rotator cuff strength, making sure that they've got the fundamentals to control that range. Because if they've got a significant deficit in and around the cuff, then they're unlikely to be able to control the movement that they need to. So once you've got that foundational strength, then take them through the movements they need to do, and get them used to repeating those movements.
Yeah,
get
just
technician back in.
Just want to pick you up on one of those points,
Yeah.
because we've got a question from Sue on topic. So when it comes to isokinetics testing and training, how much, I know because you'll speak from potentially rugby experience, definitely depends on equipment available as well, but what are your thoughts on the use of isokinetics for testing and for rehab in the return to play?
To be honest, it's not something that we've done, mainly because we don't have an isokinetic dynamometer at the training ground. But it does give you some useful information. We've used it for other injuries around ACLs and stuff. So it does give you useful information. And if it's something that you feel would add a lot of benefit to your rationale or to your profile in terms of the rehab, then great. I can't really speak from experience. Like I said, I haven't really used it.
Doug's coming in.
It reminds me, and I've completely forgotten that Len and I did this study. I don't know whether you remember.
That's what I was going to defer to you. There we go.
I remember we did an isokinetic paper as a screening tool.
Well, you did all the work, but yeah, go on.
Well, I think I got one of the students, but anyway, we decided, didn't we, that there was like ACL, anterior posterior ratios are a predictor of ACL injury and hamstring tears. Didn't we find that people who were anterior dominant, so they were a lot stronger, I think it was 60-40% ratio, a lot stronger in internal rotation compared to external rotation. They had a history of impingement, and therefore we said, okay, we'll screen the squad, academy and senior, and then we grouped the people who were, their ratio was outside of 60-40 in a shoulder group. So you had all these professional rugby players that had no shoulder problems were in a shoulder group because their isokinetic scores were outside normal limits. But yeah, I thought that was a useful exercise actually, and I still do that now. But I do it with a handheld dynamometer, and I measure right v left. So if you've got impingement symptoms, I might look at right v left, and obviously on the symptomatic side, they're going to be weak. But I always generally see that someone who suffers with impingement on the asymptomatic side, they're very, very anterior dominant. So that's quite a nice little thing to work on from a preventative point of view. And
just a technical question on that one, Doug, because I know dynamometry is something that's much more easily accessible for people in clinic now, especially with the price of dynamometry, coming down somewhat. Do you do that in a standing position where the scapula is not fixed?
No, I do it lying supine.
Right.
So they're out at 90 degrees, and I do a one rep max test, the absolute power they can produce in that position, lying flat on their back. Because if you do it seated or standing, obviously they can cheat. They get a load of trunk sway, or they stagger start.
Bring in lats and pack, and So you're really isolating the cuff.
Yeah, absolutely. And then that will be part of my return to play. Actually, can we get them pain free? Yes. And then what's their power like? Front, internal, external rotation. What's the ratio like? And then getting them right v left is before they do anything overhead.
You've teed up one of the other topics perfectly, which is great. Well done. Go on, Len. Sorry.
I just wanted to answer Sue-Ann's specific question, because she's from a place where I used to go on student holidays regularly, so she deserves my answer. So PE. She asked, is isokinetic training used from a surgeon's point of view? the biggest determinant in outcome in athletes, a successful outcome, is who does the rehab, not which machines they've done. And they've shown that with surgery as well. It's who's done the operation. So for me, it's Ethan or Doug doing the rehab, not whether they've used isokinetics or not, because I assume, correct me if I'm wrong, guys, a lot of the things you can do on an expensive isokinetic machine you can do in many other ways, but perhaps with not the same feedback. Or just clarify.
Sorry, go on.
Sorry, yeah, the isokinetic machine is the gold standard because it fixes your trunk, and but you can still cheat on it.
Is that a good thing to fix the trunk for somebody who's not going to be having their trunk fixed when they go back to their sport?
Yeah, exactly. It's not functional, but it's as every test has to be reliable, specific. So if you're comparing right v left, it's the most scientific way to do it, but it's not essential. And I haven't used an isokinetic machine for the shoulder for years, but I use a handheld now, and they're about £200. You can buy them for there's a more expensive Lafayette one for about £1,000, but no, I use a handheld one, and that's absolutely fine, I find.
Yeah, I use the same thing. We've got a handheld at the training ground, and it's very handy. Not just for impingement stuff. It's handy just if you've got someone on the bed who you can get a quick and easy access to and an insight as to what their cuff strength. It takes 10 seconds, and if you do spot some deficits, it's quick and easy to come back to. And again, if you're seeing that progress, then it's nice for you, and it's also nice for the player to actually see that they're progressing and they're getting somewhere. And actually, you can use that as part of your return to play process.
Measurables are good. We'll quickly touch on it because there's questions around muscle imbalances. So we've discussed there quite specifically cuff imbalance between internal and external rotations. As a wider point, and kind of anterior to posterior muscle imbalance a factor in impingement type injuries and posture or not? What are your thoughts? Maybe throw that to Doug and Ethan first.
Yeah, I mean, it's a difficult one because the theory makes sense. As if you're slightly anteriorly tilted at the scapula, you kind of get that pseudo flexion, and as you come up, you're probably likely to pinch. It's not really something that I look into too much, mainly because the people I work with vary in so many different shapes and sizes that if someone came in, if one of my props came in and I was worried about them being a bit kyphotic, and I basically wouldn't let them train unless I address that, then they never train, they never play. So it's not the be all and end all. I agree. I said the theory's there and it can play a part in your clinical reasoning, but in terms of posturing, I'd say no. I'd say more the muscle side of things, more the movement control side of things. In terms of more kind of gross strength, if you've got someone who benches all day, and you can see they're again internally rotated typically, I think that's slightly different to being more kyphotic, because you do find that, as we were talking about before, a simple way or a way to try and relieve kind of impingement symptoms is to add a little bit of external rotation. So if you've got someone who's naturally sitting in that medial rotate position, then you're likely to exacerbate their symptoms, or they're more prone to getting a flare up.
Potentially run into issues with using much larger muscle groups as stabilizers in place of actual
stabilizers. Yeah. So
that's as much as I'm saying without being a shoulder guy.
So I mean, going back to rotator cuff strength, really, If those things aren't going to do their job in terms of controlling the movement whilst the bigger muscles produce the strength and the power, then that's where the issues are going to come in.
Anything to add on that, Doug?
I think it's important to reinforce Glenn's point at the very start that you can do something perfectly, but if you keep doing it, it's going to hurt, you know, and that creates imbalance. If you do one movement repetitively, it could be in perfect mechanics, but it's going to eventually wear the structure out and cause, passive impingement or a secondary impingement. I've been doing more and more with the hips and trunk. If they've got painful impingement mechanics and a sore shoulder, I tend to ignore the shoulder for a while, try and get the symptoms down with sort of therapeutic treatments, and focus on their trunk and their hip. Their contralateral hip, I often do a handheld dynamometry. They usually had impingement chronically for longer than 2 or 3 months. They tend to have a weak hip on that side, the opposite side to their shoulder, and that I think gives them a give at their trunk, and that makes the shoulder sit poorly. And so a lot of the time, it's been known that I've done not a great deal of exercises on the shoulder, focused on the trunk and their hips for a few weeks, and so the shoulder sort of settles itself down. So muscle imbalance, I think, because we're shoulder physios and we're talking about the shoulder, we tend to zero. It's very tempting to zero in at that body region, but I think in the initial stages, when they're I would take the opportunity and look at imbalances elsewhere and try and correct those, rather than going, right, you've got impingement mechanics, therefore we're going to you to be able to do this better.
Great stuff. Let's just have a quick look at the questions. Okay, we'll come back to that one. It's quite a long one. Can we touch on the long head biceps question, because we had long head biceps come up quite a bit in the pre questions. I'm going to throw to Len just from a pathology perspective in terms of how common are long head biceps pathologies, how often they present in clinic, and which ones do you see most commonly?
How common? Less common than, well, it depends on your practice. Common, I mean, shoulder, so long-headed biceps is probably the structure with the highest content of neural pain fibers in the shoulder, and that's been shown. So essentially any pain in the shoulder, you're going to feel a lot of pain on the long-headed biceps tendon. So frozen shoulder, instability, all these things. So you will get long-headed biceps pain. So the question is the same as impingement. Is it primary? Is it a primary biceps pathology, which I think is quite rare, or is it secondary to something else, which is more common? So it's a process of working that out. So if you correct the shoulder position, so with the protracted shoulder, as Ethan said, and you get them back, and a lot of front row, Ethan, correct me if I'm wrong, a lot of front row rugby players have biceps pain, but very few of them ever get to me. So they're correct by good sports therapists very early on and managed, but and a lot of cuff pathology has biceps pain. So it's working out as a primary, is it secondary? So is it correctable clinically? If it's correctable clinically, it's clearly secondary. So don't treat the biceps directly. If it's not correctable clinically, and you have very specific biceps tests. So for me, Speed's test is the main one. Long-headed biceps tendinous if you press it hard enough, it's always tender. So, you know, it's comparing it to the other side as long as it's normal. Then most important is ultrasound scan. If you see fluid and inflammation or subluxing of the biceps, or arthritis in the groove or a shallow groove, those sort of things will tell you there's more of a localized pathology. And then diagnostic injections are very helpful. And then that will direct you whether it's more primary pathology or secondary. That's a very short summary. Is that okay? Does that answer your question? I don't know.
Yes,
okay.
It does. Doug, Ethan, anything on
I want to get Ethan's thoughts and experience.
Yeah, so as Len rightly said, more often than not, it's a secondary issue. So you're going to be looking elsewhere. Obviously, you can manage the symptoms for symptom relief. But ultimately, you need to play the long game and figure out what's actually causing it. Now you can go back to your dynamometry and your rotator cuff testing. That'd be something I'd look into. Is it during certain movements? Therefore, you'd assess body positions in certain movements. But I guess, like you said, similar to impingement, it's a matter of trying to figure out what eases their symptoms in terms of movement, and trying to figure out what you can do off the back of that to then try and create that movement to be more natural. To, again, similar to the proprioceptive stuff we talked about earlier, try and feel the movement where it's pain-free, try and make it more subconscious, try and make the muscles work as concurrently together as possible. And as long as you've got that foundational strength within the rotator cuff and the surrounding muscles, then that's the place you need to go. Ultimately, you need the prerequisites of your rotator cuff strength and range of motion in general, if you're going to get it to work. So if Doug's got anything to add to that.
Yeah, I think it's anterior shoulder pain, isn't it? It's the biceps is overactive, compensating for weakness elsewhere, and I liken it to like psoas dysfunction at the hip. Biceps turns into a prime mover and a stabilizer, and it's sort of overactivity ends up in inflammation and pain, and it's the thing I treat actually, because it's very hard to rehabilitate good movement patterns if they've got pain. And yeah, you work around the pain, but eventually they're going to have to do some flexion and they're going to have to come above the head. So if you can take their anterior shoulder pain down by treating biceps, then that's what I start with, and then I go down to the gym. Because if you can take their anterior shoulder pain away, they're more likely to move better. And like Len used injection therapy as a diagnostic tool, I'll do that with dry needling, and I might needle biceps to see if that helps with their pain. And that for me is, if that does, then biceps is important to get biceps right. And teach the patient about that. But biceps is probably the one thing, biceps pain or anterior shoulder pain is probably the one thing that slows everyone's recovery down. And if you can get on top of that early, then you can restore pain-free movement quicker, I would say.
Stuff we've got all the questions coming in thick and fast now. Right, okay. Len, was there any, because I saw Len that you've responded to a couple of people that had submitted questions. Is there anything that you wanted to pick up on that's been submitted already that you've gone back and forth on, or shall I dive into the others outstanding?
Dive into the others. There's definitely the what from Sahu that I definitely can't answer.
Yeah, okay, let's take that. This will be Ethan and Doug. Like we've got the hop test in our return to play for ACLs, are there any reliable tests for return to play with shoulder injuries and impingement?
In terms of shoulder injuries, I'm trying to think of ones that would be most applicable. Obviously, like we said, you can use that handheld dynamometer to give you an idea of basic rotation, rotator cuff strength. We do a dynamic press up. We've got the luxury of force plates, so we can see side to side when they're doing something like a dynamic press up or repeated movements. We can see how much is being put through each side. So even if they've got pain-free movement, it may be that they're offloading significantly onto the other side. And I guess that would similar to the hop test in that you're looking at the capacity and the overall output of the limb that you're focused on. I mean, there's no direct comparison to the hop test for the upper body because you're not going to be bouncing around on one arm. But like I say, you want
more of a data game.
Yeah,
and comparing, I guess, to previous data with things like maybe
absolutely,
three or five rep maxes pain free on.
Yes. So if you've got a shoulder injury, then you can do some general body strength tests. Like obviously you're more likely to go for a dumbbell over a barbell because again, there's cause for compensation. So in terms of general strength, then yes, that would be a good one to do. In terms of kind of movement repeatability, I guess it's difficult. You can look at isolated movement capacity more globally from upper body. Again, you can go from a 5RM to more of a capacity test if you want to, see if you're able to move a certain way a certain amount of times. So if you're looking in terms of absolute movement endurance, I guess that would be one. I'm trying to find one that would directly relate to the hop test, but I guess not. Those are the ones that we typically use anyway, in terms of absolute strength and the ability to output force and accept force at the same time. That's the important thing, especially in something in rugby. It's not just a matter of pushing someone away or handing off. It's also a matter of force acceptance, so eccentric strength. So if you're tackling someone, you need the ability to switch on, not just produce an efficient amount of force, but quickly, so you can stabilize a shoulder. Now I realize there's not many sports like rugby that you end up whacking each other, but it's a similar concept. If you've got, I'm trying to think of something that would be equivalent, but
it's the deceleration component in all.
Absolutely, yeah.
It's not just force output.
Well. It's not just force output. Some people like to go on how much they can bench when that's actually not the most important part. It's actually how much can your body tolerate, how much can your body accept. Because ultimately, the way tissues get injured is that the force acted upon them is greater than their capacity, then greater than their threshold. So yes, it's nice to be able to bench a lot and create some kind of tissue resilience, but if you're not using it properly, and if you've got a compensation pattern, or you're unable to absorb it eccentrically, then your movement patterns are going to fall down pretty quickly.
Doug, is there anything from your time? You spent a long time working in rugby union. So any additional return to play testing protocols that you would have had for shoulders?
Yeah. So we used to have a tool test with a cable, and it was the maximum amount of force. They pull it with two hands, and then it would whip back, be able to stop it going past their mid-axillary line. So we compare right v left. A 3-rep max test in this position with their elbow fixed, and then whatever they could lift times, external and internal rotation, we'd half that number, and then we'd do a time to fatigue, because obviously, if they tire, they can be as strong as they want and they can have perfect movement mechanics. But if their shoulder tires, that's when they're likely to get injured. So we would give, set a fatigue index score right v left. They do for rugby, they do a tackle cable. More right now, what I'm excited about, I'm treating a lot of motorsport athletes for some reason at the moment. And we've got a superbike rider who I'm treating at the moment. And when his neck gets tired, his shoulder gets tired. So, and the other thing that gets tired is his grip strength. So we're looking at what his grip strength and neck strength is like during the course of a race weekend, and whether that is an indicator of anything. Yeah, that's about it. And then, we would use the force platform analysis. So you how you accept weight, you can do, but without the force platform, you can do that on a weighing scales. Because when I was at Sale, unlike Ethan, they didn't have any money when I was there, so we had we had 2 weights. So they were like landing on the weighing scales and seeing how long it took them to back to zero, and then how much force they could produce. Yeah, that's what we used to do.
Just to sorry, just to go on to the onto Doug's capacity test where he talks about time fatigue. That's something we do, and something that actually someone else taught me this trade is because there's obviously so many different ways to cheat an exercise, and believe me, rugby players like to cheat exercises a lot. If you set them, it's good. It's a good way to set them a metronome when they're doing it. If you go like a 60 RPM, so they go 1 second up, 1 second down, something like that, then it standardizes the reps. Because you'll get, I've tried to do it before, where obviously not just in shoulders and anything, where they'll smash out the blocks, they'll do as many reps as they can, then they'll slow, and then you'll be like, okay, call that in the test, and like, no, I've got more. Then they'll smash out 5, and then they'll do like 2 really slowly, and then they'll go smash out 5 again. If you can standardize the reps that they're doing, then it gives a slightly truer indication of what their capacity is and when their end point is, and then at least they understand when their end point is, instead of them trying to scam you.
Yeah, I like that.
That reminds me as well, there was another one that we've done with a few players, because some of them get instability and impingement due to like a neural fatigue, particularly when they've had a nerve injury, a nerve auxiliary or something like that. So we used to get them to repeatedly tackle, replicating the game, and then see if there was a drop off in their abduction strength. We saw that as a risk factor, So Len will remember to people we sent to him with nerve issues, traction injuries, and we laugh because we'd all pass them fit in a room. And then, they'd go out and train, and they'd come in having done a full contact session for 60 minutes, and they can hardly lift their arm up. So particularly if their history was a nerve type injury, then we'd focus on return to play around neural fatigue and a fatigue index based on what they have to do again.
Good stuff. I'm just checking in on the time. So we've got approximately 10 minutes left. Len is doing an absolutely incredible job in responding to questions with links to shoulderdoc.co.uk, which is incredible. If we may, because we've not got any more questions popping in from the audience, so I want to pick up on one of the ones that has come in previously and featured quite heavily in the pre-questions as well, which was around frozen shoulder. And I think if we maybe just spend our last 10 minutes or so chatting all things frozen shoulder, and I'll go to Len first. If you've got a frozen shoulder presenting in clinic, how are you describing that to the patient and helping them to understand it? And we'll go to Ethan and Doug for conservative management, but in the more severe cases, what might a surgeon's management of frozen shoulder look like?
So frozen shoulder, atraumatic shoulder pain in middle-aged people, like Doug or Ethan, is almost certainly most of the time frozen shoulder. The other one is calcific. True old-fashioned impingement is less common once you've done the test that Doug said. So frozen shoulders are very common, and the diagnostic criteria are quite clear, although they tend to get muddied by some of the zealots nowadays, particularly on physio Twitter. It's very clear. It's a loss of global shoulder glenohumeral joint movement with persistent pain, night pain, aching pain with severe unguarded pain with sudden jarring movements, and a normal X-ray. And I think the last one's important because the two other things that can cause this are calcific tendonitis or arthritis. They're the main ones. So an X-ray will eliminate those. So and it's not how many degrees of external rotation. The commonest is they will lose external rotation, but it's not that specific, particularly when you guys often see them earlier. So they may not have developed into that level of stiffness. They may be capsulitic. So, in terms of patients, and I've had bilateral frozen shoulders. So in terms of patients, a lot of GPs will say, well, don't worry, it'll go away in an average of 2 to 4 years, which is not nice when you can't sleep, you can't function, you're drinking a bottle of wine to get to bed at night on top of the one you had for supper. It's not pleasant, the pain. So, my approach with patients is, it's self-limiting. It will go in 2 to 4 years, but, we need to manage the pain, which is usually the main issue. And the other issue for some is some functional loss of range. So I think that's really where a steroid injection or a hydrodilation with a steroid works extremely well. And, the earlier you do that, the better. Obviously, if it's not that severe and they manage well with oral anti-inflammatories and paracetamol, they don't need that. My personal opinion on rehab, and I think Doug shares this, is that it's not around trying to force or stretch the shoulder or forcing range. It's more around keeping their muscles going, maintaining functional education, modifications while they are, within that process. Does that answer your question?
Yeah, definitely. And it ties in nicely with the theme as well, this kind of, let's say, a modern approach to treatment around patient education, facilitating pain-free movement, etc., which is refreshing. And I think there's commonality across all of the things we talked about tonight, that's been the universal thing.
What's sorry to what I was going to say, it's interesting because in some countries, because you've got other countries here, so for example, in America, I would prescribe physiotherapy. And it's interesting, a lot of patients here say, how many sessions of physiotherapy do I need? I always say to them, it's between you and the physio. And for me, I guess you guys will agree, some people need weekly massage, talking, all that sort of stuff. Some patients need a little bit of education and a catch up with their therapist every once in a while. So it really is, there's no prescription. And that's what I tell patients, I'll support whatever you and the physiotherapist feel you need, and it helps.
100%. Let's touch on some of the elements you talked about, and we'll throw to Doug around managing the pain with frozen shoulder and treatment approaches. If we can do that, Doug.
Yeah, I'm the type of people that get frozen shoulder. I wouldn't know because I'm not middle-aged, but they tend to be people. They kind of pop with pain because they've got other stuff going on. So by the time I see them in clinic nowadays, they are pretty stiff. And they've usually seen a masseur, a physio, not responded that well. And so my approach is quite quickly get them in front of somebody like Len, because you know that paper where injection therapy plus physio is better than physio on its own. An intervention that helps with pain allows me to more pain-free kind of movement and mobility, gets the pain on the side really quickly. And also honesty that really we don't know why people get it, but it does seem to be a cohort of people. The type of people I see tend to suffer a bit with stress and anxiety. I think they've got a lot going on in their lives, people who get adhesive capsulitis. So I tend to talk about that as well. You know, what do they do to manage their stress and anxiety? This will get better, you know, that reassurance, we know that much, but not be too kind of focused on science and a particular exercise. And we've got to work really hard, otherwise it's just going to keep getting stiff, because they're already a type of patient that's going to get really over-focused on their shoulder problem. So try and talk about it as an opportunity to, well, you know, if we start some Pilates, if we start some yoga, try and take their mind off it. They tend to get benefit from that. So I think, you know, the sort of pseudo impingement mechanics, and we leave that on the shelf, and they tend to be like a 50-year-old person with loads going on, really stressed at that time. I mean, I know I'm being generalized, but just from the cohort of patients that I tend to see, I get them in front of someone like Len, who's also going to reassure them like I do, probably give them something to help them with their pain. There isn't a load of, you know, anti-inflammatory medication. And then that helps when they come back to me with their pain-free motion and are able to do more. It doesn't restrict their life as much. So that's a definite win. I think early referral for that, to get early reassurance and then discuss anything but the shoulder.
Great stuff. Heath, anything to add from a rehab perspective on frozen shoulders? I'm guessing you don't see many of them in elite level rugby union.
Yeah, exactly. I don't have a great deal to add because I'm not really experienced in frozen shoulder too much. But
Ethan, you see the post-op frozen shoulders, the ones that are stiff.
Yes, I guess so.
Getting back. I'm interested to know what's your approach with those.
I mean, like, we just try and get them moving as early as possible, as much as you allow us to, really. And I think that's ultimately the most important thing. If you can get it, if you can keep that shoulder moving, it's that kind of use it or lose it principle. You want to.
Do you think the external rotation brace helps? Does that make it a bit easier, or it does?
No, definitely.
So that's helpful for me to know. Yeah.
Yes, no, definitely. And the players some players have been through both, where previous operations they've been tucked in, and more recently they've been sat in external rotation, and coming out of it makes their life so much easier. Albeit the brace is a bit bulkier. It's definitely worth it, because the movement quality coming out of it is far superior to being tucked into internal rotation all the time. And that helps us to keep them moving, to reduce the likelihood of anything like this, of any kind of capsulitis kicking in. Because if we can move them as quickly as possible, we can strengthen them within their pain-free range as quickly as possible, then we can get a nice head start on the rehab process in general.
Typically, how long post surgery typically would you actually start loading them and having loaded movement?
Well, they're typically in the brace for the first couple of weeks, so you can do some light movement stuff. You can do some light isometrics. You can do some very tame band work as comfort allows, really. But as long as they're comfortable to do it, I would mildly load them almost immediately, really, because you need to get those muscles activated. Obviously, you're not throwing them on a cable machine or anything too extreme, but you need to get things fired up. Otherwise, you just got more to catch up on later down the line when you're 3 weeks deep.
Yeah, I've got one. We've seen quite a few players. Got again another story about a superbike rider, and it's not a disaster that their shoulder's stiff either. Much rather have a stiff shoulder than a really loose one. And I remember a superbike rider that had an axillary nerve injury and a really, really stiff shoulder and couldn't get on the bike, couldn't actually get the knee down. And we were like, oh God, he's going to have to retire. And so I can't remember who it was, but we got his motorbike in clinic and we didn't really understand what the tuck position was. And so his coach came along with him and then we just changed the handlebars. So we just got him in a position where he, with his limited range of movement, could handle the bike. And we couldn't explain how to get it less stiff. We couldn't explain why it was stiff in the first place. It just was. So we just had to find a solution. And then, the minute he could hold the bars and control the bike, it just didn't become a problem anymore. And I remember a tight head prop, played for the Lions, played 50 caps for England. And his trade was scrummaging and holding the scrum up. And we had, nights talking about, are we ever going to get this range of movement back? And I remember a brilliant coach, Phil Keith Roach, who was a scrum coach for England when they won the World Cup. And he said, well, let's just get him on the scrummage, teach him to scrummage differently. And I just, he can't do that. He plays for England. And he did. So I think getting the coach involved early and actually thinking through what it is they have to do, because the player will find a way of getting round, I think, right at the end of the stage. And then it becomes, not a problem that they're stiff. So I wouldn't, get over worried about getting their range of movement back right v left, and they can't play if they haven't got full mobility. Get them on the scrummaging machine or whatever, and see if they can find a way around it, because often they're a lot more talented than us, so they usually find their own way.
Yeah, there's always a solution from both angles, which is good. We've covered a lot. We have also run out of time, unfortunately. Thankfully,
United are losing.
Yeah, I know. Thanks to everyone that's updated me on that in the comments. Ethan will be pleased.
Absolutely.
Yeah, unfortunately. So I think, unlike last time, at least we've got through all the questions that have been submitted on the night, which is fantastic. What we will do in the follow-up email, as we always do, is we'll link to shoulderdoc.co.uk, Len, so that people can access your resources and information. We'll link people to Altius Healthcare if they want to look up Doug and get in touch with any follow-up questions, referrals, etc. And we'll also link them to your social medias as well, Ethan. Or if there's a better way that you want people to get in touch, let me know and I'll link them to that instead. Because I'm sure people will have questions kind of after the event, and those people that are catching up as well. Some housekeeping from me before we kick everybody out. There will be a survey just at the end of the webinar. We'd really appreciate it if you could just take 1 or 2 minutes just to fill out that survey, because it helps us to plan these events. It helps us to get the topics that you want to see, and it helps us to run them more efficiently as well in the future. If you're not already a member and you would like to support Basrat's work, you can do that with associate membership. Please just give me a shout if you'd like to discuss that. And you can follow us and Steroplast on social media to stay up to date with our work. Andrew?
Yeah, thanks, Ollie. And just really to say thank you very much to Doug, Ethan, and Len. Really great to hear from all your expertise, and it just sort of shows how important it is for all the professionals involved in sports injuries to work together. So I've certainly taken a lot away from it myself, and I think it's always interesting how much psychology comes into the treatment of injuries, and that obviously came up a few times. But yeah, thank you everyone for joining and for the brilliant questions. Great job on comparing, Ollie, so well done there, and yeah, hope to see you again next time, and yeah, just thanks again to the panel for all their time.
Thank you very much.
Echo those comments, Andrew. It's been really nice to actually do a bit of a panel format and have everyone's input and insight from different perspectives. That's been really useful. So thank you again, Len, Ethan, and Doug, for joining us. We really do appreciate it. Really value your time, and I can see a lot of thanks coming in the chat as well for you all.
No, thank you very much.
It does end quite abruptly when I kick everybody out. It does end quite abruptly when I kick everybody out. So it is farewell. Thank you for joining us. Please come along to our next one, and thank you again to our brilliant speakers. See you all soon.